Greetings, everybody. My name is Eric Valera, and I am Program Director at Latinos in the Deep South with the Latino Commission on AIDS. And we're here today to talk to you about Enlaces para la Salud, navigating HIV care for Latinos in North Carolina. We're joined in this Google Hangout today with Daniel Leva, my colleague at the Latino Commission on AIDS and Deputy to the President, and Roberto Olmos, who is the Outreach and Prevention Specialist at the Regional AIDS Interfaith Network, known to most of us as RAIN. And so, welcome, guests and presenters. I'm happy to have you here today, and this is being recorded so that we can share this with our colleagues in North Carolina and beyond. So we're going to talk a little bit about the Latinos in North Carolina and engaging them in care, and then some services in the Enlaces intervention and how the Enlaces intervention can help providers in North Carolina engage the Latino community in chronic HIV care prevention and also testing. I have want to start with some background information and talk a little bit about who Latinos are in North Carolina, what this population looks like, and what HIV looks like in the Latino community of North Carolina. I think I have some slides that will be coming up. There we go. Awesome. So, Latinos in North Carolina, and so if we can go to the next slide. Latinos in North Carolina are one of the fastest growing populations, or the fastest growing population in the state. As we'll be able to see, the population has been growing significantly over the past couple decades, particularly in the last few years, according to the census. Currently, Latinos in North Carolina make up almost 9% of the total population, which is growing and definitely a force that is important to pay attention to, especially when we're talking about the healthcare infrastructure. So first of all, when we're talking about Latinos in North Carolina or anywhere, we have to understand who they are, and that this is a very diverse group. It's a very diverse group that is made up of people from many different countries and nationalities. Some come to North Carolina from other countries, some come from other states. Many were born here. From the census data that we have, the latest data, we know that 53% of those who are in North Carolina are native-born in the United States. 78% of the births that are from Hispanics are from those who are foreign-born. So what we understand is that Latinos in North Carolina are a very young population, and they continue, and they're very young, as we can see from the school records, and that as Latinos make up 9% of the total population, they make up 13% of students ages in grades K through 12. Along with this is also understanding within this diversity that 58% of the Latinos in North Carolina are Mexican-born or of Mexican origin. So to kind of put that into perspective, when we're understanding that the diversity, that the challenges in working with the Latino community are not the same across the board. However, many of these cultural factors are things that we're going to be talking about today, specifically about culture according to healthcare, culture as it relates to gay, bisexual, and men who have sex with men, as well as how to engage this community and resources that are available be able to help um, engage Latinos in HIV care and in prevention. So Latinos in North Carolina, and if we can go to slide 3, Latinos in North Carolina um, are mostly uninsured. 43% are uninsured as of the latest data. That's to say that there are many who are eligible for expansion. Now, we know that North Carolina is one of the states that did not expand Medicaid and defaulted to a federal exchange as part of the Affordable Care Act. But that's to say that there are about 138,000 eligible people who have not taken advantage of this expansion. Most of those who are uninsured are foreign-born. Only 18% of those who are uninsured are native-born. And we're talking about health markers overall. It's not all good and it's not all bad. We know that when it comes to preventative care, Latinos tend to fall behind their non-Hispanic Black and white counterparts. And when it comes to cholesterol screenings, basic checkups, and dental visits, Latinos don't fare as well. However, when it comes to other health risk factors like high blood pressure, Latinos tend to fare better. Latinos have lower obesity rates and less prevalence of smoking within the population. On where they don't necessarily fare as well is when it comes to physical exercise, and eating fresh fruit. These are some of the markers that are important to pay attention to when really trying to understand kind of the big picture of who Latinos are and what we are paying attention to outside of HIV. Now, we're talking about HIV specifically. HIV incidence, diagnosis rates in North Carolina as of 2013. Latinos made up 8% of the new cases, of the new HIV cases in 2013. Now, when we look at the rates per 10,000, now this is in comparison to their Black and white counterparts. Blacks in North Carolina make up about 22% of the population and make up about 64% of the cases. Whites make up the majority of the population and make up 25% of the cases from 2013. However, when we look at the rates specifically, we see that there's still more of a disparity because even though Latinos make up 8% of the cases, the rates are 21.3 per 100,000. In comparison to blacks, which are 55.8 to 100,000, and whites, which are 6.8 to 100,000. So in proportion to the population, we are seeing that the numbers aren't as high, but the proportion per 100,000 in incidence continues to be higher disproportionately. Now, what's really concerning, though, is more in the AIDS cases. Hispanics make up 7% of the new AIDS cases in 2013 in North Carolina, and are making up at a rate of 10.3 percent. At a rate of 10.3 per 100,000, and in comparison to blacks, which are 34.8, and whites, which are 3.5. To really understand where what the challenges are, it's not as much that Latinos have are represented in such high numbers when it comes to HIV care or even HIV incidents. It's really more of a matter of when they're being found. Latinos tend to be found later in care. They tend to test later, and this is the case in North Carolina, where Latinos tend to test later than their black and white counterparts. Now, the challenge in this would be, we know that those who test later um, are at a disadvantage when it comes to HIV care. If those who are testing for HIV and concurrently testing for, I'm sorry, being diagnosed with AIDS, we understand that that they are disadvantaged when it comes to being able to recuperate, when it comes to being able to maintain a healthy HIV status across the board. So that's really where a lot of this concern is, being able to find and screen people early. As I was mentioning before, some of the challenge in this is that Latinos are not as engaged in access to care, preventative services, early testing. Oftentimes, many of those who are in care were diagnosed in an emergency room or hospital ward, or health department or community health center as a result of having some sort of symptoms. So this is where some of the challenges come in being able to engage this community and then being able to help them navigate the care that they need to be able to stay healthy and be successful in HIV chronic care. So at this point, I want to bring in my colleague Daniel Leva, and to talk a little bit about some of the challenges and some of the barriers and facilitators that when it comes to engaging this population in care.
Well, thank you, thank you very much, Eric, and thank you everybody for this opportunity to engage in this conversation, in this very important conversation. I would like to speak first about the cultural values around healthcare among Latinos, and I can resume this topic in one sentence. Healthcare is important if I'm sick. And that's a reality that we as healthcare providers or providers of different health-related services are very concerned about, because we have seen over and over and over people actually living with chronic conditions such as diabetes, using the same kind of terminology. You know, I'm not taking the insulin today, or I'm not doing whatever I'm supposed to do because today I feel okay. So one of the challenges that we have in this particular department is how we bring the type of education and the type of approach that actually help the people that we work with to see healthcare as a priority and not just something as a venue to find a remedy when I feel sick. I have participated in countless presentations and discussions about this topic, and it seems that always the best approach to talk about it is remembering the pyramid of priorities delineated by Maslow some years ago, in which, you know, we can categorize people can categorize their own needs according to what is the most important, what's the most essential needs that need to be covered in order to live well and to continue living in your everyday life. And unfortunately, healthcare doesn't seem to be in a very important place there. Having a job, having a stability, having a peace of mind related to financial issues seems to be very important. And then after all financial issues, I know all basic needs are covered, then healthcare is unfortunately seen as a secondary or even in this pyramid for many people. This has to do a lot, particularly, and echoing a little bit the statistics that Eric was presenting before. There are a variety of reasons why we find this, particularly with people who are living in the United States, who are not born in the United States, they grew up in the United States, and are still finding a way to acculturate and to fit into their new reality. We're talking about immigrants with 5 years of less living in the United States. And the reality is that the process of acculturation takes time. So when we find out that the number of Latino or Latino descent providers in the healthcare field is very, very low in the United States, we come to realize that, in the one hand, we have people, or we have a group of people for whom preventive health care is not one of their top priorities. And on the other hand, we don't have enough healthcare providers, doctors, nurses, even social workers that are completely familiar with the culture of many Latino immigrants in the United States. What we're talking about here is a difficulty building trust between the provider and the consumer. Why? Because we live under systems in which you get to the doctor, you get your vital signs taken, your temperature, your blood pressure, but seldom anybody tells you why. Why it's important that your temperature and your blood pressure and your pulse are known every time that you come. Then you have 10 minutes, probably, well, for some of us, I'm a person living with HIV, so for me, it's every 3 months going to the doctor and having this exchange. For many other people who we already established don't see as an important part to go to the doctor and have regular checkups in the first place, it might be even more shocking to have a doctor that is rushing you through the time. You have just a very limited time or time slot to lay down your needs and your questions. Not many of the questions get answered, and sometimes you walk out with a number of prescriptions that you truly don't understand. And here we are not talking only about people with low level of education or people who don't speak the language. I think a lot of this is happening across the board. Even people who are living who are born in the United States, with high school graduates and higher, experience this kind, or have this kind of experience with healthcare, in which they don't feel completely engaged, they don't feel comfortable asking questions. We have the very long time idea or belief that many of us carry with us from wherever we come from, that the doctor is the authority and we are there to hear, not to talk. The doctor knows better and he's going to find out. Well, we know, for experience and because it's documented everywhere, that sometimes doctors make mistakes too. And if the doctor doesn't know my history, doesn't know where I come from, whether I was vaccinated, whether I received proper care for any disease that I contracted as a child, it's going to be very difficult to build a complete profile or health profile of this individual. That's going to help the doctor to really, really, really get to the point on how to help this individual. So we have, in the one hand, the beliefs of the individual and the flaws that we find in the healthcare system. Now let's bring all these ideas together into the life of gay men, bisexual, men who have sex with men, and we are going to find out even deeper levels of discomfort and sometimes fear when talking to healthcare providers. Many people in the LGBT community, many men in the LGBT community, have a history of institutional discrimination at school, church, many of the places where we go and where we're told that we are not good enough, that the lifestyle, quote unquote, very important, that we're living is sinful, is bad. We already come with a huge charge of we are bad, and some of my choices or some of the things I have done have led me to be sick. So thus nowadays, how can we talk a little more about the stigma attached to HIV and AIDS? True, we're not living in a time anymore. I hope, and I want to believe that we're not living in a time in which the doctor, you know, uh, stop you at the door and says, "Please don't come in. You have HIV." We know how it's transmitted. We have spent thousands and millions of dollars and hours telling people how HIV is transmitted, how HIV is prevented. I think we are talking here more about the way HIV is transmitted, and we always end up with a sexual transmission. Sexual transmission still carries a huge level of stigma. And unfortunately, we as gay men are constantly reminded of that by different entities around us. So, if I already believe that healthcare is only important when I'm sick, and if I already kind of established that I don't feel comfortable with the doctor because maybe the doctor is not so interested in what's happening to me, trust me, I'm not gonna feel any more comfortable talking about HIV, having anal intercourse, having sex without protection, and the many other things that are attached to this issue. This is particularly important today because we are talking about, the advent of post-exposure prophylaxis and pre-exposure prophylaxis, PrEP and PEP. How are we going to expect for people at high risk to tell us what is happening and to give us the information that we need to probably help them get PrEP or PEP if we are not giving the opportunity to even feel comfortable at the doctor's office, or not comfortable talking about sexual activity? Um, so for us, Latinos at risk of HIV and living in HIV, there are some common issues that we're sharing. All the baggage that we're carrying and how we take this and work it out in a way that I can receive appropriate quality health care before I need it and when I need it. And at this point, what I like to invite healthcare providers, people who directly work with the community, to try to be a little more engaging in a way, understanding these fears, understanding these personal beliefs and institutional and cultural beliefs. We can make a difference by asking a lot of questions, but reassuring people that this has to do with their history, and explaining to people that the history they have behind and the way we were raised and how we were fed and how we were taken care of when we were sick throughout our lives is going to have an impact. And that's why it's so important to know what's going on in our lives. um, of course, like in with any group, this is based on a statistical information provided by many researchers telling us what the majority of people responded. However, if we know these patterns, if we know what is happening around us, I think we can start building a more comfortable space for future clients, with treatment related to HIV or to many other conditions. So at this point, I would like to leave it here, but I'm open for questions when the time is right. Thank you.
Thank you so much, Daniel. I'd like now we're going to be joined by Roberto Olmos, who's the Outreach and Prevention Specialist at the Regional AIDS Interfaith Network, known to many of us as RAIN, in Charlotte, North Carolina, to talk about the Enlaces para la Salud program and how it helps patients navigate prevention and care.
Hi, everyone. My name is Roberto Olmo. Thank you, Eric, for the introduction. I'm the Outreach and Prevention Specialist at RAIN. And what I do for the Enlaces por la Salud project, I assist with the outreach, and I also help Aleda Espinal. She's our personal health navigator, and I help her sometimes with some of her enrollments as well. I also wanted to say hello to the other site in Durham, El Centro Hispano. We have the wonderful Maritza Chirino. She's the other personal health navigator, and then Jose Alegria. He's kind of like my mirror. He does the outreach over there. So what I wanted to talk to y'all today really briefly, I know that Eric and Daniel have already talked about these topics in detail, but I'm just going to touch over them really quick. I want to talk about what HIV and AIDS looks like in Mecklenburg County specifically, and also the surrounding counties. I also want to touch on some more unique barriers that are faced by the Latino MSM, that's men who have sex with men community, and also the transgender, trans Latino community as well. I also wanted to talk about the barriers that we've seen in the field of healthcare and retention, especially among our Latino clients. Also talk about the Enlaces por la Salud intervention and why you should definitely refer people to us that you think can benefit. And also I'm going to go over the roles of the personal health navigator and any unique cases that we have seen. So what HIV looks like in Mecklenburg County today, Mecklenburg County and Charlotte, we have the highest rates of HIV transmission in the Carolinas. We rank number 14 in the nation. I believe the whole state of North Carolina is number 8 in the nation, and we're followed by Wake County that holds about 25% of new transmission. The reason that we see a lot of HIV transmission is because Charlotte is an up-and-coming city. It's a growing city. It's a really popular place to be. It's constantly being ranked as one of the newest places to move, and we're also seeing some of the fastest-growing Latino community as well here in Charlotte because we just have a lot more work opportunity, and people follow the money. So let's talk about unique barriers that are specific to the Latino community. Well, not really specific to them, but just like some of the big ones I've seen. The first one I want to talk about is Catholicism and other spiritual and cultural customs that can get in the way of a good public health intervention. When I'm talking about Catholicism, I want to refer mainly to the demonization that we have seen in the church and historically against condom usage and birth control. That's a big barrier that we see. Also, a lot of the homophobia that we see within the church that has ingrained in society as well. Also, we need to point out machismo and marianismo. Machismo is this idea of what a man is supposed to be, and he's supposed to be heterosexual. He's supposed to be, very manly, work really hard, and never get sick or never get ill. As an outreach specialist, I see this a lot of the time when I'm out doing outreach work, especially among Latino men who will sit there and they'll be like, okay, well, I don't need anything, but check my girlfriend. If my girlfriend's fine, that means I'm fine as well. Also, the idea of Marianismo, where we sit here and we believe that women are supposed to be very pure virgins until they're married. And, sometimes those kind of ideas can also translate into men as well, especially receptive partners in gay relationships. That ideal is supposed to be the same, where it's like, oh, okay, this bottom is supposed to be pure and virginal and stuff. That's another double standard. Again, back to the ingrained homophobia. We do need to point out something that's really unique about being Latino and gay at the same time is the different hurdles that we jump through in the community. Within the Hispanic community ourselves, we're treated as second-class citizens because we're gay. And then when we go into the gay community, we're treated as second-class citizens because we're people of color. And then in society as a whole, we're basically third-class citizens because we're gay and a minority as well. So those are other barriers that come into play when it comes to healthcare and retention for young gay Hispanic men. The language barrier is a big one. If you can't communicate with the hospital staff or you can't receive any information that's in your language, you're going to be basically ignorant to all that's around you, not by choice, but because you just don't know the language around you. We also need to determine the difference between, someone who has lower education and someone who just doesn't know the language. I've met Albert Einsteins that speak different languages and stuff, and I can never call them dumb. But unfortunately, we do see that a lot in our society, where these very educated Hispanic men come into the country and they just don't happen to speak English, and then they're treated as if they're dumb by healthcare providers. That's definitely not the case. But we do have to acknowledge the lower levels of education. A lot of the migration that we're seeing in North Carolina are coming from communities that were very rural back in their home country, and they might not have access to school systems and stuff. So that's another thing to point out. Also, acknowledging the differences in the medical care system. I'm originally from Puerto Rico, and even though we're a U.S. territory, somehow my grandmother can get antibiotics and other drugs as if she's going to the store to buy onions. And that's also the case sometimes when you're going to different countries as well, where it's a lot easier to get prescription drugs without a prescription. And also this idea of living in a small world. So if I move to this country and I need to be around people who speak my language, we're going to form small communities, small tight-knit communities. And within those communities, if I became HIV positive, I don't want anyone in my community to know that I'm HIV positive. So I'm going to want to go to, if my community is in this zip code, I want to go to a doctor that's on a zip code that's on the complete other side of town. Now, if we go back and talk about more barriers, let's talk about barriers for someone who's HIV positive and Hispanic, and also MSM at the same time. So again, we bring back that question about the language barrier. In my experience, a lot of the clients that I have come in with, if there's a translator present, a lot of them are just fine working with the translator. What they really look out for is if the doctor is treating them with respect and if the nursing staff is treating them with respect as well. My clients would rather come see a doctor that doesn't speak any Spanish but is respectful to them through a translator than see a doctor who speaks Spanish that still treats them like a second or third class citizen. Also, the lack of knowledge of the services that people are entitled to. This is really common that we see, especially among our Mexican HIV positive clientele. They didn't know that they had access to these services. They truly didn't know that that they could get their medications covered through Ryan White. Also, an unclear understanding of why they're visiting the doctor. A lot of the time, they'll just go in and they'll think, oh, I just got blood work done, but they don't know what blood work they got done. Also, understanding the different terminology and stuff that's used by the doctors, and again, the idea of living in a small world. And also, we got to address the transgendered issues as well. This intervention also helps with transgendered issues. We need to make sure that we are with doctors that are not only competent with working with the Latino community, but they also need to be with doctors that are confident working with the LGBT community, a big underline on T. When we're dealing with our transgendered girls, we need doctors that are going to be competent with prescribing hormone therapy along with HIV retroviral therapy. So now let me get to the bulk of the presentation. Enlaces por la Salud. This is an intervention that's going to educate a qualified client on how to navigate the healthcare system, overcome barriers, build really strong social networks, medical adherence, and also address the clash of my culture with my HIV status, and also how am I going to manage this new chronic condition that I've picked up over here or along the way. Now, the qualifications to be a client for the Enlaces por la Salud intervention is to, number one, you have to be a Mexican MSM, men who have sex with men, or a transgendered female. Um, you also have to be diagnosed with HIV either within 6 months of the first day of the intervention or be fallen out of care, meaning you haven't seen an ID doctor within 6 months of beginning the intervention. And then also, what our PHN does, that's our personal health navigator, they're in charge of working with the client and all of these issues that they're facing. So the first session that we would do with the client is we would tell them exactly what HIV is, what an undetectable viral load is, why you want to become undetectable. We also talk about, like, especially if they're in relationships with negative partners, we push PrEP that idea of being undetectable as well. We also talk about like how their religion and how their cultural customs come into play with HIV as well. We'll try to break down some barriers, but we'll also use their strengths as well to build up their knowledge and build up their self-esteem so that they can self-navigate living with HIV. We also run through scenarios of like, what do you do if I'm a monolingual Spanish-speaking person and there's nobody that can translate? We assist them with scenarios like that, and we also rehearse those back and forth. Um, this intervention is not something that is designed to replace case management at all. If you currently have a client that meets these qualifications, you can just refer them to the intervention and we will work with them. This is a tool for case managers to use to help strengthen that relationship between provider and case manager, and also strengthen the relationship that the person has outside of the healthcare system as well. Um, the person doesn't necessarily have to be in case management to do it. This is also a really good way to prepare someone to get into case management as well. Um, and we also like to stay in touch with the participant after this. It's 6 sessions, 6 2-hour long sessions. The participants do get paid to participate. And we try to get the sessions done within 3 months, no longer than 6 months. And we like to follow up with the participant as well with the healthcare provider to make sure that they're becoming undetectable and to make sure that the intervention actually worked, and if there's anything else that they would like for us to work on with the client. I see I only have a few minutes left, so let me just throw out some examples of some of the case studies that we've seen here at RAIN. So back to what you were talking about, Eric, about how our young men are getting diagnosed with AIDS at this point instead of getting an HIV test while they're still healthy. Our first 2 clients that got enrolled actually had CD4 counts well under 100 and uncontrollable viral loads. And that tends to be a very common thread that we see with the new clients that come into us. And this is because people aren't getting tested regularly. Just like y'all said about preventative care, we really don't believe in it. And we got to work on that. We also have an issue. We had a client came to us that had toxoplasmosis and was given a handful of pills along with a handful of antiretroviral therapy, and they had absolutely no clue why they were taking these pills. So our PHN had to educate this participant exactly why you're taking all of these pills and the importance of taking them all and making sure that they took all those pills. Luckily, that person has turned around and is doing really well. Also, we've been working with clients that have comorbidities. We have a client that has renal disease and living with HIV as well. So we're not only working with them on managing their HIV, we're working with them on how to manage the renal disease and making sure that they're seeing specialists as well. I know it's kind of a little bit the role of a case manager, but if there's a case manager present outside of the PHN, we would be making those referrals to the case manager, and the case manager would have to make the referrals to whatever specialist is out there. Also, this idea of a lack of knowledge and a lack of education with the medical care system and a distrust. We've seen clients that tell us that Powerade is controlling my HIV. Therefore, I don't need to take any medicine because the Powerade is doing the job. We educate again on the importance of medication adherence, and exactly, we acknowledge that the Powerade is making you feel better, but we need you to take the medicine. And also another trend that we're seeing is this clash of my birth name and my alias that I'm using over here. We've had about 3 cases so far where clients are going in to get tested under one identity, but then wanting to get medical care under their original identity. So our PHN has been working on with clients, with the case manager, and everyone else needed to handle that situation. And I will be around for the question and answer afterwards. Thank y'all so much.
Great, thank you so much. And I mean, both you, Roberto and Daniel, brought up some really great and interesting points. And I want to, kind of bring in a discussion with us three and kind of bring some of this into perspective. I've been in that position of being that case manager working with the Latino patients, and one of the things that I encountered quite often is that even those who have been in chronic care consistently sometimes really don't understand their diagnosis. Sometimes don't have very little understanding of what their CD4 of what the CD4 count means, of what their viral load means, despite the fact that they're told at every visit that what their counts are. And I think this kind of goes a little bit to what you were speaking about, Danielle, about having your provider as the authority figure. And part of empowering the patient is really being able to help them understand their diagnosis, not so that they just keep coming back and taking their medicines, but also to be able to help understand and explain this to others and be able to kind of overcome that stigma. And Daniel, maybe you could tell us a little bit about, you can talk a little bit about that from your perspective.
Yeah, I mean, thank you, Eric. So one of the things that gotta say, I've been living with HIV for many years, many years. I was diagnosed in 1997. So I have seen the many changes. I've been part of the many changes in the healthcare field related to HIV. One of the things that I think was the worst mistake, I cannot put it any other way, was to get rid of treatment education programs as they existed many years. And even though the scenario of healthcare has changed and the needs of people living with HIV are changing, the need to understand medication, side effects, interaction with other medication is still not only pressing, is essential uh, for people to continue accessing healthcare and trusting healthcare. Unfortunately, nowadays, we talk so much about the medication available, and here is not only for people with HIV. We're only moving into the prevention aspect now that we are promoting, help promote the idea of PrEP as a way to help those at a higher risk to prevent HIV and AIDS. We are still not telling people what's that imply, how medication, any kind of medication that you're going to take on a regular basis is going to affect your blood pressure, your liver, what are the implications of drinking alcohol, bad nutrition, illegal drug use. We are just so focused on medication and treating this specific condition. Something that we as people working in organizations that serve the community and particularly Latino communities can do is number one, we need to continue advocating to have these programs like Enlaces. And this is not a commercial. I don't work for Enlaces, but I just heard the description, and it fits so importantly some of those needs that we have. We are in New York City, and we have the exact same problem you can find in the smallest, most remote town anywhere in the United States. You can find why? Because it's not only access. Access without education has the potential to sometimes do some harm rather than fixing the issue. Let me just talk very quickly about a situation in which I was. years ago. One day I'm getting dressed to come to work, and the next thing I remember is a number of firefighters around me in my bedroom asking me the name of the president and what day is today. And what's going on? Well, as it happened, one doctor, one provider prescribed me some kind of medication, and a different provider who knew my history, okay, and a person with whom I had a relationship as a consumer doctor still prescribed something that went against everything the literature said. As a result, I was suffering seizures because of the, the mistakes that were made in prescription. Well, yes, it's true that I'm still very angry with that provider. The reality is that I realized, after so many years actually working in the field and knowing what I know, how little empowered sometimes I feel when confronted with the doctor. I still believe somehow that the doctor is the authority and they know what they are doing. Well, I'm not bashing doctors here, but the reality is that we need to have the space to really talk openly and honestly about the implications of not empowering and not educating consumers about what are we putting in our bodies. I'm not anti-medication. I'm just saying I need to know what's going to happen to me and how am I going to manage it when it comes. Just to wrap it up, I come from a time where you didn't know what was worse, the side effects of HIV. I'm sorry, the the little diseases and discomfort you get because your immune system is compromised, or the side effects of the medication. Sometimes I couldn't make a difference between what was worse. It really helped me to get close to people who knew about these issues and to be educated. So I was in that position with all the tools I have to my disposal. Let's move it into many people in the community who cannot see a doctor for different reasons because cost is prohibitive, because lack of access, because there is still lack of access in the current environment. Aside from all the other issues that we discussed before, so treatment education is really, really, really urgently needed, not only for people with HIV, but for anyone who is trying to manage a chronic disease.
Thank you. Yeah, and there's some really great points there too, because when we're talking about the institutionalized stigma, the stigma of being for sexual orientation of being HIV positive, on top of that being the stigma of being Latino in healthcare. It brings up a lot of there's a lot of identities that need to be navigated just through going through healthcare, and I really appreciate, Roberto, what you were saying when it came to how Enlaces is not a replacement for a case manager. When I was a case manager, I would have loved to have this type of support with my Latino patients, because in the challenge of helping empower them sometimes is in conflict with what we do. It would be much easier to be able to have a resource where we know that they're receiving this level of empowerment, so that our level of conversation is at a different level, and it is less taxing on the case manager. You can tell us a little bit about how Enlaces works with medical providers, and how can medical providers contact you guys and make a referral for Enlaces?
All right. So, thank you, Eric. The way that the program works directly with medical providers and case managers, we need to take into the account how much a case manager works. Here in Charlotte, I can count probably off of my head, maybe I know about 15 to 20 case managers in the city of Charlotte. and there's over 6,000 people living with HIV in Charlotte. So I can't imagine how those clients are being divvied up among case managers. So this is especially the case with someone who has an extremely high caseload, and you don't speak Spanish. The client does. You have no way of communicating. We speak Spanish, so we'll be able to educate the client on how to work with you and work with the provider as well. A big thing that we teach the client is to, write down your questions before you see the provider. Make sure that your translator is ready for you before you go see the provider. Um, they can come to us and get their questions translated so that it can be read by the provider, and we can translate it for them back if the doctor has no way of translating it in the meantime. Um, we also want to maintain a communication with the provider by asking the provider some questions that we can know about the client's health. So if there are releases of information that can be put into place between the personal health navigator and the provider, what we would like to know is, like, how has their CD4 count and viral load improved since they started the intervention? And if there's anything that we need to know, and if there's anything that the case manager should know about the client in particular that can improve their outcomes. Also, we really push the idea of telling the client that the client needs to share. Your doctor should know about all your conditions. All your doctors should know about all of your conditions, and your case manager should know about your conditions as well. Now, we are completely confidential, so we won't divulge anything to the provider that the client does not want us to divulge, and of course, we don't divulge that to anyone. We can kind of act as the confidant for the client as well, but we do encourage constant communication with the case manager and open communication with the doctor. I know the way that you can get in touch with us here in Charlotte. You can visit www.carolinarain.org. That's CAROLINARAIN.org. You can reach me at r.olmo@carolinarain.org. Or you can call me at 704-973-9814. Again, that's 704-973-9814 to make a referral, at least in the Charlotte region.
And also, I think along that line, it's important to also realize that Enlaces also operates on the other side of the state, at Durham at a Centro Hispano. As you mentioned earlier, being the patient health navigator, and Jose Alegria, working there as well. So it covers a large part of the state, of the whole state of North Carolina. So I think this is an important resource that should be used for providers across North Carolina. And I think in that, we want to really be able to thank them and all the providers at this point who are working with Enlaces. As I said, it's there's a lot of challenges that we're working with in the Latino community, and being able to engage patients across the continuum of care, from prevention all the way across to being able to help keep our population virally suppressed if they are HIV positive. And we really appreciate being able to speak with everybody right now and help understand the importance of empowering the Latino community, and empowering the Latino patients within the clinics and in the community, to be able to help stamp out the stigma, and to be able to help with the cases that exist and keep people healthy. So at this point, I want to thank my guests, Daniel Leva and Roberto Olmos. Also want to thank Christine Carcano, who is the coordinator, the Enlaces coordinator at the University of North Carolina, as well as the North Carolina AIDS Technical and Education Center for their support. And the HRSA SPINS project for their support of the Enlaces program as well. please you can go to the Google Hangout and ask any questions that you might have later on, and Christine will be able to answer any questions that you might have offline through this Google Hangout page. And thank you very much for joining us today.